can be analogous to blood pressure monitoring for somebody who has high blood pressure. And it can give you a type of physiologic abnormality, but not necessarily a specific diagnosis. So it's a piece of the puzzle in making a diagnosis, if you will. So with spirometry, we can measure forced vital capacity, timed volumes like forced expiratory volume at 1 second, flow rates like forced expiratory flow at 25th to 75th percentile. There's also other flow rates that can be measured. If there's reversibility of obstruction, if obstruction is present, we can give medication and see if it improves afterwards. And just kind of general guidelines for FEV1, at least actually a 12% or higher change in FEV1 is considered reversibility of obstruction. In the FEF 25-75, it's a greater than 25% change between the pre-bronchodilator and the post-bronchodilator percent predicted. And that just means that the chances that the percent change is due to the medication and not to other factors such as a difference in technique or other things, it's actually due to the medication. So why would we want to do spirometry? The main reason usually is to see if there's any airflow obstruction. So trying to see if there's airflow obstruction in either the large or the small airways, or also is there a restrictive process. Now, basic spirometry can give you a hint at that, but it can't formally make that. You also need lung volumes in addition to that to fully make that particular determination. Also, if you want to see if there's an improvement or a decrease from previous testing, and then the magnitude of abnormality if it's present, and as we just talked a little bit about, is there any change after bronchodilator administration if you're thinking your patient has an obstructive process. So this is just a diagram of the different capacities and volumes that can be measured with spirometry and full pulmonary function testing. And I'm going to go over just briefly a little bit about that. So the 4 volumes that we can determine are inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. And often in an obstructive process, if there's a lot of air trapping going on, the residual volume will be elevated. Usually 2 or more volumes added together will make a capacity, and there's 4 capacities. So there's vital capacity, inspiratory capacity, functional residual capacity, and total lung capacity. And sometimes the evaluation of lung volumes may require special equipment and may need to be done in the pulmonary function lab depending on the type of equipment that you have available. So the vital capacity, which is total lung capacity minus residual volume, is generated by maximal inhalation followed by maximal exhalation, sometimes also referred to as forced vital capacity when you use as much force as possible. FEV1 is the forced expiratory volume at 1 second. So 1 second into the forced expiratory maneuver, the volume that has been blown out. And that's analogous to kind of the larger airways, if you will, kind of a measurement of what's going on in there. Peak expiratory flow rate is the greatest flow rate obtained during the expiratory maneuver after complete inspiration to TLC. And there again, that can be analogous to peak flows the portable peak flows. FEF 25-75 is the average forced expiratory flow between the 25th and 75th percentile of the forced expiratory volume at 1 second. And I'll show you a diagram of that in just a second. And then forced expiratory time is the length of time of forced expiration. And then this spirogram is either a volume versus time graph or a flow versus volume graph, which is helpful in evaluating not only the shape of the curve, but also if it's good technique or if there's maybe other things going on. Sometimes that can give you a clue as to where it might be happening. So this is just a diagram of how the forced expiratory flow 25th to 75th percentile is determined. And essentially it's really the maximal slope of the curve if you want to go all the way back to geometry. And it gives us an approximate measurement of peripheral airway flow, but it's not as an accurate measurement as, say, the forced expiratory flow volume at 1 second, because, first of all, this is calculated mathematically, and it's not as a sensitive measurement. So most kiddos can do spirometry by about 6 years of age. Now, there are some very smart, precocious children who, with a lot of coaching, can sometimes even do them down to 2 years of age, but I think that's more usually luck and excellent skill of the person doing this spirometry, as opposed to, really most kids is by the time they're 6 or 7. And really for spirometry in pediatric patients to go well, you need to minimize distractions as much as possible, and so that would be making sure that the environment is as quiet as possible. Distractions may also include parental help in quotation marks, if you will. So sometimes, depending on the child, having mom or dad nearby is helpful, and sometimes it's not helpful because the parent wants them to do their best and they're just making the situation worse. So you have to be a little aware of that and redirect the environment if you need to. The child should have an erect thorax and their head should be in a neutral position. So in younger children, that can be in a seated position or standing position, usually standing. In adults, I think they recommend more of a seated position. Nose clips can be helpful because it just helps to minimize any influence from blowing in and out through the nose. And then, of course, you want to explain to the child what's going to be happening and what they need to do before you proceed. The patient needs to hold the mouthpiece between their teeth and make a tight seal with their lips. And you have them do a few tidal breaths to kind of get the hang of it, and then a big, deep inspiration and a really fast, as prolonged an exhalation as possible. And oftentimes we'll hear from the other room, blow, 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 and you can do it. And a lot of coaching really helps and motivation, because 6 seconds doesn't really seem like a long time, but when you're trying to blow all the air out of your lungs, it seems like it's forever. And then you record the best of 3 tries. In younger children, depending on the equipment you have, there may also be visual cues on the actual screen, which may also help the child. So like inflating a balloon, or I think there's one with a rooster crossing the road. You're trying to get the rooster to cross the road, or blowing out birthday candles. So other consideration is, in addition to the age of the child, would be actually the personality of the child, the interest level of the child, and the developmental age of the child. So we all know some 4-year-olds that could probably do spirometry without any problem, and we know some 9 or 10-year-olds that just, for whatever reason, can't seem to get the hang of it. And if the child can't do spirometry, that's okay. We try again the next time, because sometimes kind of they need a little bit of exposure to the idea of it and kind of what's expected, and by the 2nd or 3rd time they can do it. So what are the standards for a valid test? So you need at least 3 acceptable maneuvers that meet the start of test, which means there's a rapid inhalation followed by almost immediately by forced exhalation, and end of test criteria, meaning that they basically blow out as long as possible to that expiratory reserve volume. And timing needs to be, for younger children, at least 3 seconds. For older children and adults, it's at least 6 seconds. You also need to have repeatability. So you need to do the best 2 acceptable tests have to be within 150 milliliters for both FEC and for FEV1. And you can keep trying up to a maximum of 8. And usually beyond that, the person's getting pretty tired, and you're just getting the law of diminishing returns there. So this is what a flow volume curve looks like, and exhalation is on the top part of the curve. It looks kind of like a the top part of an iceberg, if you will, or a mountain, and then the bottom part is the inspiratory part. So generally for the results, you're given the absolute values and the percent predicted values, and those are based usually on a reference population of the same age, height, gender, and sometimes race or ethnicity. The other important thing to know is to know which reference standard you're using, because if you're trying to compare results from your institution to another institution's, if they're different reference groups, the percent predicted may be slightly different. So when you get your spirometry results, what do you do? So first thing is you want to make sure that the age, the height, and the gender are correct. And sometimes because all of those can affect the percent predicteds that are printed out. Then you want to evaluate the patient effort. Is it good technique? So do you have a straight kind of line going straight up followed by sort of a mountain slope afterwards? Or is there a lot of what I would call noise or a lot of up and down in the exhalation part of the curve? Is the forced expiratory time adequate? So is it at least 3 to 6 seconds depending on the age of the child? You want to evaluate the shape of the curve. You want to look at the FEV1 and then look at how it is compared to the predicted, so what the percent predicted is, and then you want to look at the FEV1 to FEC ratio. And looking at that can give you an indication if there's an obstructive versus a restrictive process, if it's depending on what that is. And then also look at the forced vital capacity and the FEF 2575 and compare those to the reference values. So in an obstructive process, the forced vital capacity can be either normal or decreased. The FEV1 can be decreased. The FEF 2575 is usually decreased. The FEV1 to FEC ratio is decreased. Total lung capacity may be normal or increased depending on the amount of air trapping. In restrictive disorders, the forced vital capacity is usually decreased. The FEV1 is decreased, but the ratio of the two is normal or increased. So that's where that FEV1 to FEC ratio can be helpful. The FEF 25 to 75% may be normal to decreased, and the total lung capacity is usually decreased. So with an obstructive process, the flow is usually lower compared to the lung volume. So it takes a longer time to get the air out, is the way I like to think of it. So that's why the FEV1 is decreased, because you have that obstruction present. The air is trying to go through a smaller tube than normal. And for it to be considered an obstructive process, the FEV1 to FEC ratio is less than 85% of predicted or 80 absolute value. And these are some examples of obstructive processes, of course, asthma being the most likely one that you're going to see. The flow volume curve on the exhalation part of the curve has a concave shape. So it looks, instead of like kind of a gentle mountain or a right angle of a triangle, it looks more like a ski slope. And sometimes you may see obstruction appearing in the small airways before the large airways, because if you'll remember, especially for asthma, the process starts in the small airways first and then moves centrally as you get more and more inflammation and obstruction. If you see a flattened inspiratory curve, that can also mean that there's some upper airway obstruction going on. And so you may need to do some further looking into that. For a restrictive process, you may see normal flows, usually normal flows and reduced lung volumes. And the FEV1 to FEC ratio can be normal or increased. And examples of that might be obesity or neuromuscular diseases or scoliosis or interstitial diseases. And you would need to get lung volumes to really clarify what's going on there. These are some examples of acceptable and unacceptable spirograms, and I know you had a whole workshop on this, but probably of these the most common are here, which would be coughing kind of during the middle of the exhalation part of the test, variable effort, which kind of looks like two like camel humps, or you can see that they did not reach that kind of peak of inspiratory effort followed by forced exhalation. They kind of took a little bit of a breath in and blew out, and took another little breath in and blew out. And then on the bottom corner, the glottic closure, it seems like there's an early termination of the forced expiratory flow at the end of the curve, as opposed to kind of going all the way down to what would be the x-axis there. So we've looked at the numbers, we've looked to see if they're normal or abnormal, but how do we categorize the amount of obstruction or restriction if present? So for forced vital capacity, generally 80 to 100% of predicted is considered normal. And some of these, depending on your sources, the percentages for the different classifications may vary by a few percentage points here or there, but kind of the same general concept. 70 to 79% is considered a mild reduction in forced vital capacity. 50 to 69% is a moderate reduction, and less than 50% is severe reduction. For FEV1, normal can be anywhere from 75%. Some folks will use 80% of predicted. Mild obstruction is considered 60 to 75%, and a moderate is 50 to 59%, and then less than 50% is severe obstruction. If, for the severe obstruction category, if the patient is less than 25, you add 5% onto that, so it would be more like 50 to 55%, and if they're 60, you would subtract 5%. And part of that's due to the decline in FEV1 as we age and what's considered normal. For 25-75%, as I had mentioned before, this is not as accurate as some of the other measurements, but generally greater than 79% is normal. 60 to 79% is considered a mild obstruction. 40 to 59% is moderate, and less than 40 is severe. So this is different than the classifications that we use for like mild, moderate, severe asthma. This is the amount of obstruction present. And then we talked about looking at the FEV1 to FEC ratio. So just as a reminder, these are the classifications of asthma by severity. Sorry, had to take a drink there. So for mild persistent classification of asthma, the FEV1 is greater than or equal to or greater than 80% of predicted, and you have a normal FEV1 to FEC ratio. For moderate persistent, in looking at the spirometry, FEV1 should be greater than 60% of predicted, but less than 80%, and the FEV1 to FEC ratio should be reduced by 5%, so that would be 75% or so. And then severe persistent kind of follows a similar step there. And up at the top of the screen, you have the normal FEV1 to FEC ratios. Now, this is just a part of the puzzle, because if you remember, for classification, you also need to look at the type of symptoms that are present and how frequently they're occurring. So if you have kind of a disconnect between the symptoms occurring more frequently with normal spirometry, you would pick the more severe category for the classification in that case.
And that's why there is actually a direct
Right.
association between spirometry and symptoms. So we don't always treat the numbers. Sometimes you just have to go and listen to the patients and listen to their stories to determine the severity of asthma.
Right. So I have some questions for you all, and then we'll, how are we doing? We're doing okay on time. So the first question is the spirometric index that best distinguishes between restrictive and obstructive pulmonary disease. Is it A, forced vital capacity, B, forced expiratory flow 25 to 75%, C, FEV1 to FEC ratio, or D, FEV1? And if anybody wants to shout out what the answer they think is appropriate. These are all easy questions, too, hopefully.
And remember, if you need to unmute, it's *#.
take a stab at
Okay.
it. Is it C?
Uh-huh.
Oh,
Correct. The FEV1 to FVC ratio.
Michelle?
yes.
Did anybody have a question?
Someone said Michelle?
I think that may have just been
Yeah.
Inner.
yeah, discussion.
Yes.
So this is the second question. Predicted values on the spirometry test are based on A is height, B is weight, C is gender, D is race, and E is choices A, C, and D.
Christy and Fran say E.
They are right. Hey, Christy and Fran. Okay. And the main thing is that is weight is not really considered in the predicted values. Question number 3. To accurately assess spirometry, you need to look at A, the forced expiratory time, B, the shape of the flow volume loop, C, degree of change pre and post bronchodilator when evaluating for reversibility of obstruction, D, FEV3, or E, A, B, and C.
E.
Right again. Yay, 100%. You can look at FEV3, but that's really not a measurement that's standardly used in evaluating spirometry, but it may be helpful, I don't know, at some point for something. Okay, so I guess we'll stop here. Does anybody have any general questions so far? And we had 2 cases sent in. One was from Michael Lentz and one was from Dr. Kasimsap. Sorry if I'm not saying your name correctly. Are either of you there?
And it looks like Dr. Kasimsamp's patient will not be presented.
Will not be presented. Okay.
Right, so just Dr. Lentz. Are you on, Michael Lentz?
I'm here, and I have my patient. I trust you got my fax or my email with the pulmonary function report.
Uh-huh.
We did. Clancy did receive that, and we have some around the room, and we'll put it up on the screen here in a second.
I'll start. I have a 16-year-old football player. It was seen by Dr. Morosi in 2008. At that time, Dr. Morosi's diagnosis was asthma, mild obstruction, with non-adherence to medication. And what I found interesting was that I hope you have in front of you the spirometry that was done in 2008, I believe, and the ones I just did this week. And to me, they look essentially the same. At that time, she placed him on Advair Discus 250/50, Ventolin as needed. He swears he uses the Advair every day, and he basically uses the Ventolin as needed for exercise-induced asthma before football practices and games. I'm seeing him for other things. I'm seeing for his persistent systolic blood pressure. He's not on any medication. His weight is 270 pounds. His height is 73 inches, and his BMI is 36. He does not smoke. Has never smoked. There is smoking in the house. He again uses his Ventolin as needed for football. He denies nighttime cough. I honestly have never seen him or heard him wheeze. There's no history of hospitalizations or oral steroids. I checked with the pharmacy to see how adherent he was with the medications, and in a year he's filled 5 Advair Discs, and he hasn't refilled any in 60 days. Again, telling me after I've asked him 3 times if he does this every day, and he says yes. My interpretation, and I am really new at this, so forgive me, but it seems to me that his forced vital capacity is normal. His FEV1 is in the normal range. But what continues to below is his ratio of the FEV1 to the FVC, and his peak expiratory flow is also very low. I think these tests are done well. I think my medical assistant did a good job on them with the timing. Your impression would be helpful. So my questions are, what am I looking at here? Why is his ratio so low? Why is his peak expiratory flow so low? And what should I do with him? So that's my question.
So I have a couple questions before that. So how